Okay, hi guys. So here we go, another snow day. It's a little crazy outside. I don't know if you've looked out recently. So let me just make sure that everything is working correctly here. Seems like it is. Okay, sorry, just need to make sure. I have done a whole lecture before and realized that it wasn't recording, so trying to avoid that. Okay, so today is really part one of the focus on hypertension. So today we're going to focus on the incidence, the prevalence, and underlying mechanisms. So just as a reminder, because there were a couple people that didn't seem to recall what these two terms meant. So incidence is really the rate of new cases. Okay, so this is the first time this person's been diagnosed. Whereas prevalence is really a snapshot in time looking at a population, which could include not only those who have just recently been diagnosed, but also those who have been diagnosed in the past. So it's a little bit more wide reaching, a snapshot of how many people in a particular area do have hypertension at any given time. Okay, so we're also going to start exploring the idea of underlying mechanisms, and that's going to lead us in very nicely to next class, focusing on hypertension when we start talking about different therapeutic interventions, really how hypertension is managed largely through medications, although, of course, diet and exercise seem to play a role as well. So, worldwide, and this of course comes from the World Health Organization, elevated blood pressure is estimated to cause 7.5 million deaths. That's approximately 13% of all deaths. So, this is really wide reaching. Again, not just the US, although we know this is a really big problem here. It's a big problem all throughout the world. And towards the end of the semester, we're going to start looking at how this is really an epidemic. There are certain countries that are starting to really be affected at a drastically increasing rate by things like blood pressure. We also see here at the bottom that elevated blood pressure is a major risk factor for coronary heart disease, ischemic, and hemorrhagic stroke. So this is not news to us. We've been hinting at this from day one. Blood pressure seems to be involved with pathogenesis of a lot of different aspects of cardiovascular disease. So if you can identify and manage blood pressure, you can understand the significance. Okay, so aside from those complications that we just talked about, so being a major risk factor for coronary heart disease, ischemic and hemorrhagic stroke, there are other comorbidities that seem to come with elevated blood pressure. So that is heart failure, so especially when we think about congestive heart failure, and remember that this really represents an ineffective pump, so the heart is not going to be effectively pumping blood out to the rest of the body. It's also involved with peripheral artery disease, so that is the accumulation of atherosclerosis in the peripheral vasculature. Renal impairment is a big one, and so we're going to talk about the differences between two different types of hypertension because renal problems can cause hypertension, but hypertension can also cause renal problems. So, kind of a chicken or the egg situation, and in some cases it might be a bit of a vicious cycle. Now, there's also implications with retinal hemorrhage, so that is bleeding of the retina, of course, and then eventually visual impairment. So, this is another one of those things that is sort of used as an early indication of somebody who's suffering from high blood pressure, which I know we've mentioned in the past. So, optometrists, ophthalmologists, people in that general field of study have been really focused on trying to identify retinal hemorrhage and therefore suggesting to people that they need to be referred to another physician to further explore the potential for high blood pressure. So when we say high blood pressure, and we're going to break down some additional categories, we're going to get a little more detailed coming up, but high blood pressure is really referring to anything greater than 140 over 90 millimeters of mercury. So it's 140 millimeters of mercury for systolic blood pressure and 90 millimeters of mercury for diastolic blood pressure. So in those that have high blood pressure, 69% of them were people who had their first heart attack, 77% who had a first stroke, and 74% who had congestive heart failure. So you can see the relationship, the powerful relationship of high blood pressure with these major life-threatening events. Now, the Center for Disease Control, the CDC, has put forth a lot of information. So if this is a topic you're interested in, there's no shortage of really interesting facts online. So from the CDC, from The NHANES data, we'll see a little bit of that from the American Heart Association, from the World Health Organization. There's lots of information out there. So the CDC shows us some values here, looking at the percent of adults aged 20 years and older who have hypertension. So let's focus on the top table there. So people who have been diagnosed with hypertension, and you can see there's two different lines here, one that says age adjusted and one that says crude. So when you see the word age adjusted, this is a tool commonly used in epidemiological research, so really large population-based research. And it's really a mathematical way to weight or to account for, to adjust for age differences, because we know that hypertension is really a disease of age, right? So there are definitely younger people that can have hypertension, but we know that it becomes drastically more prevalent with age. So age adjusted really kind of flattens out the age influence. It's just a mathematical way to adjust for that. So you can see that this data starts all the way back from 1988 and it extends out to 2012. So for age adjusted, we actually see that there hasn't been a huge increase in the prevalence of hypertension. So you see 25.5% in 1988 to 1994, and then it reaches 30% in 1999. And you see that, a little bit of fluctuations, but from 2011 to 2012, it was again at 30%. So this is age adjusted. Now, if you look at crude, meaning not age adjusted, you can see that it has steadily increased. So really what we're looking at here is the impact of a growing aging population. Now, the bottom table shows uncontrolled high blood pressure amongst persons with hypertension. So it's really looking at the people that we've already identified in the top table and what percentage of those people have uncontrolled high blood pressure, meaning it's either not treated at all or it's not effectively treated. So you can see, again, we have age adjusted and crude. So largely, no matter what line you're looking at here, whether it be age adjusted or crude, you can see that there has actually been a steady decline in those who have uncontrolled high blood pressure. So you should be thinking to yourself, why is this? One obvious explanation would be an increase in screening. So, this is widely practiced amongst all physicians. And of course, we have other resources outside of the doctor's office to learn about our high blood pressure or regular blood pressure. So another thing to consider here is treatment. And that's definitely one thing that has advanced over decades, is the effectiveness of different blood pressure lowering medications and understanding of lifestyle behaviors that affect blood pressure. So we have gotten better at that. We can be happy about that. So here you see some NHANES data. So remember, that's that truck. There's many different ways they do this, but they do have those trucks that drive all around the country and collect population-based information. So we have prevalence of high blood pressure in adults aged 20 and older. And of course, this is a little bit old, 2007 to 2010. There are some new information from about 2013, but it looks very, very similar. And I'm apologizing now for the crappy figure here. I know it's not very easy to read, but we see on the x-axis we have age in years, and we have age groups, so everywhere from early 20s, early 30s, all the way up to greater than or equal to 75 years of age, and then percent of the population on the y-axis. Males are in blue, females are in red, and just like we talked about with the gender or sex differences in cardiovascular diseases, we do see that men have a higher prevalence of high blood pressure until the age where menopause seems to hit for most women. So you can see right around 55 to 64, we start to even out, and then women start to take over. So like we talked about, this could be related to menopause and the sex hormones, so especially the decline in estradiol and progestin. So that's one thing that we can take away from this figure. Of course, the other one is that, and no surprise to any of us, this is an age-related disease. So it starts off around, anywhere between 6 and 9% of the population that have high blood pressure between the ages of 20 to 34, and it steadily increases, quite a linear relationship, all the way up to greater than age 75, 72 to 80% of that population. So most people are going to develop hypertension unless we come up with some drastic means to prevent it. Now, you can also see that prevalence is expected to increase by about 7.2% by 2030 from 2013 estimates. Again, we have a growing aging population, so this shouldn't be surprising. So some more really interesting facts from the NHANES data from 2007 to 2010. Those with high blood pressure, or of those with high blood pressure, about 82% were aware that they had it, 75% were under treatment, 53% had controlled it, and about 48% had not controlled it. Okay, so there are a few things we need to point out here. First of all, at least our screening procedures seem to be effective in that most people are aware that they had high blood pressure. Now, of course, we are missing, just a little bit less than 20%. So could we improve? Definitely, but that's not a terrible number. 75% were under treatment. So that's also, favorable. Of course, room for improvement, but about 75% of those that had high blood pressure were trying to control it. Okay, now these are the ones that are less than optimal, in my opinion, and this corresponds nicely with the table that we saw in the last slide, or a couple slides ago. So 53% have controlled it, and about 48% have not. So, I mean, this is pretty close to 50-50. Only half seem to have controlled it and half seem to have not. So that's definitely something that can improve. So then we see adults 20 and older in the U.S., of those that have high blood pressure, we see that there are differences in ethnic backgrounds. So we have non-Hispanic whites, non-Hispanic blacks, and Mexican Americans. So for the most part, this is something we'll talk a little bit more about as the semester progresses, but this is something that seems to affect non-Hispanic blacks more than whites, more than Mexican Americans. Now, for the most part, too, we see that for these populations, men have a slightly higher percentage of high blood pressure than do women. However, that is not true for the non-Hispanic blacks. So we see that 47% of women in this category have high blood pressure, whereas 43% of men have high blood pressure. So there's a slight shift in that relationship there. So we can say pretty confidently, though, that this affects non-Hispanic blacks more than non-Hispanic whites, more than Mexican Americans. Okay, so I mentioned that there are actually other categories of classification for hypertension. So we know that normal is considered anything less than 120 over less than 80. Pre-hypertension, so where you start to get a little concerned and there would be more monitoring and then potentially an early intervention, would be somewhere between 120 to 139 over 80 to 89. So most of the time, if you go to the doctor's office and you have a reading that's within 120 to 139 over 80 to 89, they really won't think anything of it. So you can actually adjust your blood pressure many ways. And if you get a little bit nervous, nobody really likes being at the doctor's office, or something recently happened that day, you're a little stressed out, you're trying to get to the doctor's office, your blood pressure will go up. So, if there are repetitive records of you approaching that, the upper range of the pre-hypertension values, they might start to intervene. However, most of the time, I think you'll find that people don't actually start getting interventions until they reach stage 1 hypertension. So you can see stage 1 is anywhere between 140 and 159 over 90 to 99. And stage 2 is anything greater than or equal to 160 over anything greater than or equal to 100. So there are classifications here, and we're going to see that these are also important when determining realistic ranges for controlling blood pressure, because it's very unrealistic to assume that somebody with stage 2 hypertension can get back down to normal. That's very, very, very rare. So you have to adjust expectations. Okay, so I mentioned that there are 2 different types of hypertension. There's essential, sometimes known as primary hypertension, and I'm just going to throw up the other one right now. Secondary hypertension is the other option. The large majority of cases of hypertension, you can see greater than 90% of them are essential hypertension or primary hypertension. So this is challenging because this is the type of hypertension that is idiopathic, meaning no idea how it started or where, why it's occurring. And so this is thought to be a combination of genetic and environmental factors that contribute to the development of this type of hypertension. So that's really challenging when it comes down to treating these. because you don't really know what caused it. So you're just treating symptoms at that point as opposed to treating the origination of the cause. Now, with secondary hypertension, we pretty much know what the cause is. So it's either renal, endocrine, neoplastic, neurologic, or cardiovascular. So in this case, the treatment can focus on eliminating the cause, and then therefore hypertension is managed. So this is a much smaller percent of cases. I'll give you some ideas of what diseases cause this in just a second. Okay, so focusing right now on primary or idiopathic hypertension. So there's no known cause. It usually clusters with other types of risk factors for cardiovascular disease. So aging, not a surprise, being overweight, being insulin resistant, so really some early stages of diabetes, if you have full-blown diabetes, and then hyperlipidemia, which is essentially increased concentrations of cholesterol and other types of fats like triglycerides circulating in the blood. So we're going to talk, after we get through this lecture and the next lecture on hypertension, we're going to talk more about hyperlipidemia. But these are common risk factors for the development of cardiovascular disease, and they're normally coupled with hypertension. Now, we also know that hypertension develops gradually. This isn't something you don't have one day and you just have the next day. So, because it's a combination of genetic and environmental factors, it develops over time. It's really a function of, aside from genetic factors, it's a function of lifestyle behaviors. One of the issues with hypertension, of course, and because it develops gradually, is that early on there might be some subtle damage. But a lot of times this is hard to pick up because these people won't have signs and symptoms. So unless they happen to go through some stress test or a physical of some sort and they happen to look at some of these markers, that wouldn't be detected. So some of the subtle organ damage that takes place early on will be left ventricular hypertrophy. So the left ventricle muscular wall will enlarge slightly. Microalbuminuria. So albumin, of course, is a really large protein that circulates through the body, has numerous different functions, including other proteins and molecules will attach to it in order to travel through the blood. But because it's such a large protein, and it's a protein in general, the kidneys normally do not allow for protein to wind up in the urine. So they resorb them, they put them back in the blood. And so this is especially true. It's true with all proteins, but especially with albumin because of its size. So microalbuminuria represents that there's a small amount of albumin in the urine. So that's normally an indication that there is some level of damage at the level of the kidneys. Another possibility would be beginning stages of cognitive dysfunction. So perhaps this is memory-based, perhaps it's problem-solving based, spatial awareness. This is particularly difficult to detect early on, but possible. So as hypertension develops further and the individual gets on later to life, there might be some catastrophic events that occur due to long-term uncontrolled high blood pressure. So, of course, this is stroke. It might be ischemic or hemorrhagic, and we're going to talk more about that in the coming weeks. Myocardial infarction, renal failure, and dementia are possible. So you can understand that this is very serious. These are all major events. Now, with secondary hypertension, again, this is really a small percentage of cases, somewhere on the order of 5 to 10%. It has an identifiable cause. So here, not an extensive list, but here are some ideas of some of the known diseases that can cause hypertension. So secondary hypertension, essentially referring to the fact that it's a ramification of one of these diseases. It's secondary to the primary disease. So renal artery stenosis, you can have a narrowing of the renal arteries that can cause hypertension. Chronic renal disease, as soon as you have problems at the kidneys, you should just start assuming that there's going to be some level of hypertension that occurs. Now, of course, people that have renal issues are normally very aware of this. This is normally something that physicians that are treating these people are very attentive to. And so, one good thing is that they can be treated early on. And so it won't develop into something very major with a lot of organ damage. Primary hyperaldosteronism. So aldosterone, we're going to talk a little bit more towards the end of today, but it is a hormone that is involved in retaining sodium at the level of the kidneys. So if you retain sodium, that also means you retain water. Water follows sodium readily, so if you retain sodium in the body and you don't pee a bunch of it out, you also retain water, and that is going to affect blood pressure through the cardiac output side of that equation. So you increase total blood volume, that's going to increase pressure on the arterial wall. Stress can also lead to hypertension, and we'll make a connection at the end of today's lecture with the sympathetic nervous system that I think will be a little bit more clear. Sleep apnea is kind of a funny one. So because there are periods where during sleep these people actually stop breathing, this increases blood pressure. So you are creating a high pressure system, and there's a lot of different reasons why this might be causing hypertension, but essentially people that have sleep apnea need to be very attentive to that. Hyper or hypothyroidism. So this can be overactivity of the thyroid or underactivity of the thyroid, and the thyroid is really responsible for regulating metabolism. So if you have alterations in the hormones that are related to metabolism, this can also negatively impact vascular resistance. It can impact a lot of different factors that will lead to hypertension. So it's a little bit more of a convoluted mechanism, but not uncommon. Pheochromocytoma is actually a tumor of the adrenal glands. So it's a tumor that actually secretes hormones still. It's really an interesting thing. So it could be aldosterone secreting, it could be cortisol secreting. Either way, it's going to secrete a hormone that can lead to overactivity, really. So it's going to secrete more of a hormone that will lead to hypertension. Preeclampsia, of course, is blood pressure, high blood pressure that develops during pregnancy. Causes are actually quite unknown at this point, why somebody would develop preeclampsia. And so not only do they have high blood pressure during pregnancy, but they seem to also run the risk of developing high blood pressure later on in life, even though right after birth, their blood pressure normally returns to normal. And then aortic coarctation, which is the extreme narrowing of the aorta. So therefore, there's more of a challenge for the heart to push blood out against that narrowing artery, and therefore, it's more work on the heart. It's really creating hypertension. So this brings us to the concept of age-related stiffening of the heart and the arteries. And this is something that's still really being studied, although there are some mechanisms that have been identified. So consider the other side of the blood pressure equation. If it's cardiac output times total peripheral resistance, we're really going to focus now on the aspect of total peripheral resistance. So normally in healthy individuals, of course, the arteries can easily expand and contract. They're sort of pliable, if you will. So with age, and this is really a function of primary aging, however, secondary aging can be superimposed in this case. So people who have poor lifestyle behaviors, it can be much worse, this age-related stiffening of the heart and the arteries. Okay, so the mechanisms are numerous. I'm actually going to skip ahead a little bit to show you what some of them are. So why does this happen? It really points to the innermost layer, the endothelium. We're going to talk quite a bit about the endothelium in the upcoming slides. And really what winds up happening is that it thickens and it also fragments. So it really gets disrupted and it proliferates. So it thickens, it hypertrophies, if you will. Okay, so why does this happen? There's a cross-linking of connective tissue. So it forms, you can kind of see, I know you guys can't see my cursor as we found out last time, but hopefully you can see a little dot here. There's this matrix-like organization of this tissue, and it cross-links, it gets even more matrix-like, it interweaves itself, and probably due to a few different things. So due to fat and smooth muscle proliferation, so fat in this area and the smooth muscle can expand in volume. There's also an increase in collagen in this area, and this is kind of a funny thing with collagen because with age we do see that collagen decreases in a lot of tissues, and some of it increases. So collagen is going to be the main component of connective tissue in this location. So if you increase collagen, you increase connective tissue, and we know that connective tissue doesn't expand and contract like the endothelium typically does. So overall, this increases peripheral vascular resistance, and this is a function of age, and there are some studies that show about 1% each year. So not anything you can do anything about. It's primary aging, but of course you can at least help your chances of mitigating additional effects if you practice good lifestyle behaviors. So that was really talking about the arteries. Of course, there are structural changes in the heart too. Again, just simply a function of age, but lifestyle behaviors can be superimposed. So we know that there's an increased left ventricular stiffness and wall thickness. Of course, left ventricular hypertrophy occurs just with age, but it's exacerbated with things like hypertension. You see a 30% increase in wall thickness from age 25 to 80, and these are people without hypertension. Okay, so this is something that just happens. Of course, it's exaggerated in disease states. And then I want to bring up this term afterload, which I think we briefly mentioned before, but so afterload is the pressure that needs to be overcome for left ventricular ejection to occur. So this is really what we've been referring to when we talk about systemic hypertension. So if you increase the pressure in the arteries that the heart has to pump blood against, this is really describing afterload. Okay, so there's increased afterload, and really what this is thought to be occurring from is reduced arterial elasticity. So if we go back to the previous slide talking about stiffening arteries, they're no longer as elastic anymore. Therefore, they can't adjust their diameter as well as they could when they were younger. And therefore, this can increase the pressure that is exerted on the arterial wall and therefore on the heart. So we've definitely identified left ventricular hypertrophy before, but just to keep in mind, it can be drastically enlarged. So if you look at the right side of the screen here, the right picture, I mean, that's a seriously enlarged heart, right? So not only is the musculature hypertrophied, but you can see the diameter of the ventricle is really, really, really small. So this is, of course, a maladaptation to hypertension. This is one of the results of long-term uncontrolled hypertension, and it will diminish pumping capacity. It can cause death, especially if you look at the heart on the right side. If that person didn't die from this, they were just about to. Okay, so another structural condition we need to think about within the heart, aside from the tissue enlarging and becoming more stiff, the heart valves also get affected with age and with disease. So the valves increase in size and thickness. In this case, the collagen fibers in this tissue are actually thought to degenerate, as opposed to in some of the other tissues, it's thought to accumulate and therefore increase connective tissue, increase the stiffness of that tissue. So in the valves, there should be a lot of collagen. It is a stiffer material. That's fine. It should be stiff. So degeneration seems to occur with age, and therefore they aren't. They're more pliable in this case. Another thing that happens is lipids start to accumulate in this tissue. Valves can start to calcify, and that's something that can be picked up with a CT scan. You see that there's really, and these are as a function of some of the things we've already identified, there can be valve leakiness and valve narrowing. So, of course, leakiness really will result in regurgitation. So as blood gets pumped into the next chamber through the valves, the valve might not close all the way because of some of these changes we've identified above, and therefore blood will leak back a little bit. So this is an inefficient tissue, and it results in regurgitation. You can hear this in many cases, so it presents like a murmur. Now, there's also increased aortic valve stenosis, so the valve itself will narrow over time, and this is normally a function of the calcification, the lipid accumulation, and perhaps damage as well, and so remodeling. So there's less of an opening for blood to push through. Now, what results from all these changes is really an increase in resting blood pressure, and that's the biggest concern. We expect blood pressure to increase during something like exercise. That's totally normal, totally healthy. But if you're resting and your blood pressure is high, that's concerning. So, of course, why does this happen? Thickening of the arteries is definitely one thing. So I wanted to point out here that there is a 20 to 50% increase in arterial resistance with aging. So this is significant. This is a large change that happens with age. And I also wanted to bring up the components here of blood pressure. So we normally just say increased resting blood pressure, but there are some differences between systolic and diastolic. So with systolic blood pressure, this is really seen with increased total peripheral resistance and or large arterial stiffness, excuse me. So if somebody has elevated systolic blood pressure at rest, it's due to one or both of these mechanisms. So total peripheral resistance, really referring to some of the arteries outside of the central system here, or it could be due to large arterial stiffness, so the aorta especially, and then also some of the coronary arteries that are quite large, or even up towards the carotids. Now, with diastolic blood pressure, this gets a little bit more confusing, and people are still trying to understand this exactly. So if you have an elevation in diastolic blood pressure, it could be due to increased peripheral vascular resistance. However, if you have stiffening of large arteries like the aorta, it can actually induce a decrease in diastolic blood pressure. So diastolic blood pressure is really difficult to interpret because even in pathological states, it could be elevated. It could also be decreased, and both of which could be dangerous situations. So especially referring to the latter here, if there's an increased stiffening of the large arteries, that means, again, that they're not able to change their diameter that well. So if they stay perhaps a little bit larger than they should be, this would decrease diastolic blood pressure because they wouldn't be able to adjust appropriately during the resting phase of the heart. So this will actually decrease the amount of pressure that's exerted on their walls. So there's many different ways to look at this phenomenon. And again, sorry about the quality of this picture, but I wanted to point out, this comes from a very specific study. We don't need to really pay attention to the details here. But I wanted to point out there's not only diastolic and systolic blood pressure that we can look at and try to understand, as we see on the bottom panels. But in the top panels, you see two things, one being mean arterial pressure and pulse pressure. So mean arterial pressure is really just the mean of systolic and diastolic, and it's thought to really indicate perfusion of organs, so the amount of blood flow delivered to the critical organs. So this is commonly used in medicine, especially like surgeries and even nurses. This is a really commonly seen variable up on a life support system or something like that. Now, with pulse pressure, this is the difference between systolic and diastolic blood pressure. So you can see the millimeters of mercury for pulse pressure will be, anywhere between like 40 and 49 millimeters of mercury. So this is important, especially when we think about the previous slide, because let's say due to large artery stiffness, diastolic blood pressure is actually really, really low, but their systolic blood pressure is really, really high because of some similar or different mechanisms. So these people do have high blood pressure, but their diastolic is very low. So this is something that can really pick up on that, and this is thought to have a lot more clinical significance than just looking at diastolic and systolic blood pressure by themselves. Okay, so when we think about pathophysiology of hypertension, it involves multiple pathways, and so far 4 are really focused on. Of course, there are additional contributors to hypertension, but here are these systems that are thought to play a big role. So endothelial dysfunction, pro-inflammatory pathways, the sympathetic nervous system, and the renin-angiotensin-aldosterone system, otherwise known as RAS. So the upcoming slides are really going to go through each one of these individually, and we're going to start with endothelial dysfunction. Okay, so remember that endothelium is the innermost layer of the arterial wall. And, really something that can cause endothelial dysfunction will be high blood pressure, high LDL cholesterol, remember that's the bad cholesterol, glucose intolerance, smoking. These can all lead to endothelial dysfunction. So it's kind of an interesting thing. You see high blood pressure can lead to endothelial dysfunction, and endothelial dysfunction can lead to high blood pressure. So it's kind of an interesting relationship there, a vicious cycle, if you will. Okay, so within endothelial dysfunction, there are really 4 different pathways that are focused on. So one is increased superoxide production. Superoxide is produced, it's a free radical. Okay, so it's a reactive oxygen species. So especially if you don't have a sufficient antioxidant response and you have an increased production of superoxide anion, This will actually decrease nitric oxide production, which, if you remember, is a very potent vasodilator. So in healthy individuals, and this is seen with increased exercise habits as well, that they have an increased presence of nitric oxide, which causes dilation. So in these people in the pathological state with endothelial dysfunction, you have decreased nitric oxide, which decreases dilation. And this also induces, superoxide also induces remodeling. So now we have one of the mechanisms that can lead to expanded volume and stiffness of the endothelial wall. Another molecule of strong interest is endothelin. So if you have increased endothelin, you have increased constriction. Okay, so now we have two different mechanisms that are leading to increased total peripheral resistance, really changing the diameter, making it smaller. So with increased superoxide, we have decreased dilation, and with increased endothelin, we have constriction. So all in all, we have a smaller diameter of the arterial wall due to both of these mechanisms. Now, the next box points to inflammation. We're going to see some more examples of this in just a second, but with inflammation, we see leukocyte adhesion. So white blood cells start to adhere to the endothelial wall. This might be something like a macrophage, which, if you remember, adheres to the endothelial wall. It will eventually, what's the word I'm looking for? Extravagate into the plaque. It will start to eat up a bunch of the fat in that area, a bunch of the cholesterol and things and triglycerides. It becomes a foam cell. If you recall, it's like a big fluffy macrophage. It releases all of those different pro-inflammatory substances that degrades the capsule in the plaque. And then, of course, we can eventually see plaque rupture. Now, another one that we haven't talked much about is an increase in cyclooxygenase. So that's what you see there, the increased COX. So there are a couple different COX pathways, and this is really what like anti-inflammatories like NSAIDs, like ibuprofen, really interact with. So with an increased production of cyclooxygenase, this increases thromboxane A2. That's what that molecule is there, TXA2. And this leads to thrombosis. So of course, this is essentially coagulation that we're seeing here. If you upregulate cyclooxygenase, you upregulate the clotting response, which of course can lead to thrombosis, especially if you have a plaque rupture. So all of these together lead to hypertension. Now, aside from endothelial dysfunction, we also identified pro-inflammatory pathways as one of the mechanisms of hypertension. So this, you can see, is again a cycle, and we start off with pro-inflammatory cytokines. So people with chronic non-communicable diseases like cardiovascular disease do tend to have low-grade inflammation. So this means that they excrete more pro-inflammatory cytokines. So remember, cytokines are signaling molecules. So this includes the interleukins, so IL-1, you can see they've identified here, and also tumor necrosis factor alpha. So there are many others. These are just some examples. But you can see these lead to three different options, excuse me. So they're in the circulation. They also, if we go to the left, will induce a release of IL-6. And in this case, IL-6 is identified as a messenger cytokine. It also seems to have some roles in pro-inflammation. And so at the level of the liver, this IL-6 presence is thought to induce the release of C-reactive protein. So remember, CRP is one marker that can be used to identify chronic inflammation, and it's used to identify beginning stages of cardiovascular diseases. Now, if we go to the left, you can see that these pro-inflammatory cytokines also induce a greater presence of something called ICAM. So this stands for intracellular adhesion molecule 1. So ICAM 1 is really something we've been referring to this whole time. So ICAM 1, if it's released, it's a marker that actually will reside on the surface of the endothelium, and it is what's going to allow for adhesion of leukocytes. So this is really how we're going to start getting immune cells, especially macrophages, inside the plaque, and that's really what this is trying to represent here, is a plaque that's developing on the endothelium wall. So ICAM situates itself. It allows for the attachment of leukocytes, and then it will eventually allow for extravagation of those leukocytes inside the plaque, meaning it will allow them to enter the plaque, and that's when we start to see foam cells, release of pro-inflammatory markers, et cetera, et cetera. Okay, so now I'm gonna, the other two mechanisms we had for hypertension were the sympathetic nervous system activation and the renin-angiotensin-aldosterone system. So I want to take a step back and describe these hormones a little bit. Of course, these are hormones that I am particularly interested in because they're also known as fluid regulatory hormones. So they really adjust the system to account for dehydration, overhydration, etc. Okay, so we have angiotensin 2, arginine vasopressin, and aldosterone. Now, angiotensin 2 does promote fluid retention and consumption. It's also a potent vasoconstrictor. Arginine vasopressin, or AVP, also used to be known as the antidiuretic hormone, or ADH. Nobody really uses that term anymore. Some older folks and also some Europeans still use it, but largely it's referred to now as arginine vasopressin or just vasopressin. Okay, so it is antidiuretic. That means you have a reduction in urine volume, meaning you're retaining water. Okay, so the presence of AVP actually acts on the nephrons in the kidneys, and it allows, it's sort of like a last attempt to retain fluids if you're dehydrated. Lastly, we have aldosterone, and aldosterone is really noted for promotion of sodium reabsorption. So I've identified really the primary function of these hormones, but they are sort of multifaceted. So for example, aldosterone not only is known to promote sodium reabsorption, but also water. There's a couple other mechanisms for the ones above as well. Okay, so water follows sodium like crazy. Sodium has a really strong attraction for water. So anywhere sodium goes, you can assume water's going with it. So if we retain or reabsorb sodium, we're also going to retain water. So I want you to think back to the blood pressure equation being cardiac output times total peripheral resistance. These three hormones are actually going to affect both sides of that equation. So if we retain sodium and water, we're going to increase cardiac output because we're going to have a greater blood volume. And if we have some molecules that are also vasoconstrictors, we're going to affect the total peripheral resistance side of the blood pressure equation. Now, there is one other hormone that actually is there to do the opposite. So the top hormones are really going to be upregulated. They're going to be in greater concentrations in the blood when you're dehydrated in order to retain fluids. And on the flip side, if you drink too much, you have the release of a hormone called atrial natriuretic peptide, or ANP. So, as the term suggests, atrial, it is actually stimulated from, its release is stimulated from the right atrium. So if you have an increase in blood volume, this is a great place to sense this, of course, because all blood goes back to the heart. So if there's a lot of blood volume, it will stimulate stretch receptors in the atrium, and those stretch receptors will then release or signal the release of atrial natriuretic peptide. So AMP will increase urine production, and it will antagonize or sort of prevent the functions of the hormones listed above that are primarily responsible for fluid retention. So it's going to do the exact opposite of what the hormones above are doing. Okay, so these hormones are related in the renin-angiotensin-aldosterone system, otherwise known as RAS. So, I know you can't really see my marker, but if you see in the middle of the screen, we have angiotensin 2, like we talked about first. So angiotensin 2 is going to be created once renin is produced. So if you look at the bottom left-hand side of the screen where the kidney is going to release a hormone called renin. This is going to cleave angiotensinogen to angiotensin 1. We see there's another hormone called ACE, which is the angiotensin converting enzyme that is not only seen in the renal endothelium, but also in the lungs, and it cleaves angiotensin 1 to create angiotensin 2, our functioning hormone that's a vasoconstrictor and also serves to retain fluids. Okay, so that's why it's called the RAS system, because it's the renin, angiotensin, and then aldosterone you see is actually going to come into play right after the angiotensin 2 label here. So if you look directly to the right, you see the adrenal cortex is going to secrete aldosterone for sodium retention as well as water. Now, if you look down, all the way down from the blue dotted line coming from angiotensin 2, and you see the pituitary gland, the posterior lobe, and ADH secretion. So, of course, this is also known as AVP or arginine vasopressin. So that's where we see the release, the stimulated release of AVP. Now, a couple other things we see. With angiotensin 2, if you look all the way at the top, this causes increased sympathetic activity. So remember, the last two mechanisms we were going to talk about were the RAS system and sympathetic activity. So sympathetic activity, of course, we're thinking fight or flight. This is also going to eventually release things like cortisol. So anytime you think of sympathetic activity, you should be thinking elevated blood pressure. That's, there's going to be a variety of different mechanisms there, but this is going to, again, be part of like a vicious cycle. So you will increase blood pressure simultaneously with the RAS system. Okay, so we're going to see this figure again next class when we start talking about how we manage blood pressure, because there are many, many, many different types of pharmaceutical interventions that will interact with this system in various different locations. Okay, so what's the real problem here? Aside from increasing blood pressure, there are other effects where certain molecules within the RAS system seem to impair vascular and metabolic health. So this figure is really just focusing on angiotensin 2. There is now an increasing accumulation of literature looking at other molecules like aldosterone and AVP as well. Okay, but looking at angiotensin 2 as an example, if we have an elevated angiotensin 2 in the blood, this will cause endothelial dysfunction itself and vascular remodeling. It'll elevate blood pressure. It'll also lead to atherosclerosis. So there are a variety of different mechanisms now that link angiotensin 2 to these functions that we've already discussed. It also appears to play a role in glucose intolerance. So this is a crazy thing, that there are other tissues, including adipocytes or internal fat cells, that have their own RAS system. They produce these hormones. It's really a crazy thing. It's like its own little microcosm. So within fat cells, they appear to be pathological with the cardiovascular diseases and metabolic diseases as well. And they release a variety of different mechanisms that lead to glucose intolerance. So that's why you can see there's this intermingling of things like diabetes and other metabolic diseases that lead to, or obesity, that lead to things like high blood pressure or cardiovascular disease, and also vice versa. So, which one came first? Sometimes hard to tell, but it is really common to see these comorbidities together. Okay, and we already kind of pointed this out, but I wanted to make sure that this is really clear, that the RAS system and the sympathetic nervous system are really related. So with angiotensin 2, we saw that there was an increase in the central sympathetic nervous system activation. One of the ways that we see that this is present is there's an increase in norepinephrine release. So, of course, norepinephrine is involved in sympathetic activity. There's also some other nerves that start to play a role, so especially in the renal tissue, in the kidneys. So you see the renin release, and there's a couple, I'll get back to those letters, Greek letters and numbers in just a second. You also see vasoconstriction gets caused with increased sympathetic activity at the level of the kidney. There's also increase in sodium and water retention and vascular remodeling. Okay, so there are some receptors. We see the beta-1 receptor, alpha-1 receptor, that are really involved in these mechanisms. So if you have an increase in sympathetic output and you have an increase in norepinephrine will play a big role in these particular receptors. So the beta-1 receptor, the alpha-1 receptor, and then we'll also see epinephrine primarily acts with like beta-2 receptors. So there's a lot of different receptors that other pharmaceutical interventions will interact with, again, to control blood pressure. Okay, so that's all we have for you for the first section of hypertension. So next class, we will go on to explore how we manage it.